Greetings to the day, folks. Today we are going to discuss fever evaluation in a neonate and infant less than or equal to 3 months of age. So, in infants less than 3 months of age, we must review birth history, including the length of gestation, use of peripartum, antibiotics in the mother, and during the labor or during delivery, the presence of neonatal complications such as like fever, tachypnea, or jaundice, signs or symptoms of any serious bacterial infection, typically non-specific in this age group. So, for example, like vomiting and diarrhea accompany many other problems, including gastroenteritis, otitis media, UTI, meningitis. So, if the infant is crying, it may be a manifestation of serious bacterial infection or a benign condition of the infancy, like colic or hunger. So, we must be careful enough to just be sure whether it is a serious or a mild one. Okay, so for evaluation, we must undress the infant completely, assess the age appropriate normal vital signs. Tachypnea or hypoxemia may be clue. Okay, so it may be clue to a lower respiratory tract infection. Inconsolable crying or increased irritability when handled is frequently seen in infants with meningitis. And although fullness of the anterior fontanelle may be noted in some infants with meningitis, other signs of meningeal irritation such as nuchal rigidity are usually absent. So we must perform a head to toe evaluation to identify a focus of infection such as inflamed tympanic membrane or evidence of cellulitis. So if this is present, it may be suggestive of the localization. So, treatment of infants and units and infants less than 3 months of age with a focal source for fever is controversial. In small study like tympanocentesis confirmed acute otitis media, and there are no cases of bacteremia or meningitis, but UTI was found in 9%. Sample size was not adequate, and okay, so a recent study that used a step in Europe used a step-by-step approach and evaluation of the febrile infants without source of fever identified a population of infants with a low risk for a serious bacterial illness that could be managed on an outpatient basis without use of antibiotics or lumbar puncture. The study used physical appearance, well appearing or not, age cutoff of 21 days, and urinalysis and biomarkers in a stepwise fashion to identify these infants. The low-risk group of infants still had a rate of missed serious bacterial infection of illness of 0.7%. So therefore, even within identified source, laboratory testing, close monitoring and follow-up, especially children less than 3 months old, are recommended to detect occult infection. Thank you.